Okay, so it's 12:30, so we'll get started. Welcome to this didactic presentation is on quality improvement in geriatric following geriatric patients and implementing a FALLS program. So without further ado, let the speakers, Dr. Sutherland and team, go ahead.
Good midday, depending on your time zone. My name is Brian Kane, and I'm proud to be part of this team on the didactic. This is a conjoined presentation sponsored by both the Evidence-Based Medicine and Healthcare Interest Group and AGEM, our Academy on Geriatrics. The goal of this didactic is to coalesce a multi-center group that's going to work on implementing a FALLS program, and it is our hope that that group will apply for the inaugural Engineer Award named after Rakesh Engineer, who unfortunately passed a few years ago. And that award recognizes implementation science. So without further ado, I think I'm turning things over to my colleague, Sean. Sean.
Thank you, Brian. So the title of our project is My QI Project Has Fallen and It Can't Get Up, Implementing a FALLS Program. Next slide, please.
Did it go?
No. Great. Yes. Now we got. Oh, yeah, one back. Great. So, we'll be presenting basically guidelines to help you start a FALLS implementation program. So the first question is always before you start a project is, why would you want to implement a FALLS or a safe mobility program? Well, for one thing, falls among older adults are very common. In fact, 1 out of every 3 community dwelling older adults falls annually. And this is no surprise given that we see these patients, oftentimes in our shift every day, whether or not it's in acute or in our lower acuity areas for ankle sprains and whatnot. This is at a cost, there's a huge cost to our healthcare system, upwards of about $50 billion, according to the CDC, in terms of geriatric fall-related injuries. And what's important to note, even if these patients are coming in for a sprain or for some type of laceration and they're discharged, the fact that they fall will double their risk for future falls. Next slide. So the falls, in terms of the impact, can range from minor to fatal. On one end of the spectrum, there's psychological stress, fear, loss of confidence, social isolation, and this may impact people at various times. It may impact the older so which is the 80 and above or 90 and above, more so than the 65-year-old who falls during skiing. But on the other end of the spectrum, we know that falls are the #1 cause of death due to injury among older adults. And in fact, oftentimes, your residents or your medical students or your colleagues will say that there was a mechanical fall. And this is rarely the case, that an environmental hazard is the sole cause of their fall. In fact, falling is often a sign of systemic pathology, and we like to think of falls as sentinel events that deserve a sentinel response. So the idea that when you have the headache and you're worried about that sentinel bleed, the fall is similar in that this is a sentinel event, and that patient will fall again if you don't realize and work up why they fell in the first place. And the mortality rates can be very high. They range from between 2 to 11% 6 months after the patient is present in your ED after a fall. Next slide. So what can we do? Well, the first thing to do is understand what the fall risk is for your patient, as well as what you'll decide to do for your intervention. In terms of identifying fall risk, you can use tools such as the Geriatric Emergency Department Guidelines, the STEADY, which is from the CDC, and the Joint Commission also has fall guidelines. And the next issue that you'll have to tackle is, what intervention will you be implementing? So will this be solely in the emergency department, which has the advantage of basically you controlling it. And if you only have funds to implement something while they're in the ED, this may be the only place where you can actually impact your patient, and they're essentially a captive audience. However, we do know from many studies that falls are multifactorial in etiology. And so a strategy often needs to reflect that. So you'll often need multiple providers across multiple sites, such as primary care, physical therapy, or home safety evaluations. Next slide. What are the data that that are out there about interventions that are based in the ED or related to ED patients. Well, data are mixed. This is a busy slide, but this is just for your reference. And if you need it for when you're actually writing up your proposal, this will be on the AGEM website in the future. But essentially, Baroff, Shaw, and Russell found no effect in terms of falls. And the most famous one probably is the PROPHET study by Close, which was published well over 20 years ago, but showed a significant decrease after their intervention. And more recently, Lesser and Goldberg have shown that in the ED, their interventions can actually impact recurrent falls. Lesser basically, in a large database study, showed that having PT was associated with decreased future falls in terms of fall visits. And Goldberg, who launched the Gap Care, did an intervention with PT and pharmacy and showed that there was a decrease in recurrent ED fall visits. Next slide. So before you start any intervention, what are the challenges and the barriers to implementing your program? And my colleagues will talk about understanding these challenges before you implement something is very important. So one, time is of the essence in the emergency department, no surprise. And the intervention for falls reduction is often time consuming. So for example, in Dr. Goldberg's Gap Care study, it was approximately 20 minutes for physical therapy and 20 minutes for pharmacy. So if you have those resources, understand that that patient is probably going to spend another 40 minutes in your ED, although in her study, the length of stay for these patients was really no different between the control group and the intervention group. And the screening and intervention components of your fall program are often complicated. So because they're multifactorial and they assess multiple etiologies, they're much more complicated than, say, doing a D-dimer for a PE or sending a troponin and sending an EKG on a chest pain patient. These are more complicated and will take more time. And third, in some of our work, we found that sometimes patients are not ready for that intervention. So if they come in for a fall, they're likely more of a captive audience, but certainly if you're going to be screening all geriatric patients, you can understand why a patient who comes in for, say, some type of abdominal pain, why we're asking about their fall risk factors. So these are things to consider as you're implementing your fall program, but things to think about before you even start. Next slide. So this is a meta-analysis from about 20 years ago, but if you are looking for bang for your buck in terms of what are your biggest risk factors for future falls, muscle weakness, a history of falls, gait deficit, and balance deficit are often associated with the highest rates of future falls. And so we recommend that probably any study that you do or any intervention that you do would include some assessment of strength, because that will likely be most correlated with a future fall. Again, a history of falls and some type of gait testing. And again, always looping in the patient with their primary care doctor, because oftentimes studies have shown that patients don't go to their primary care doctor and report that they've had a fall because there's so many other issues that they're tackling, like high blood pressure, depression, etc. And any fall program will have to address how to get your patient to exercise, because this will increase their muscle strength and their balance. And at the very least, whatever you do in your falls program, it will be imperative to raise concern with the patient and help them understand that a fall, even if they don't have a significant injury, often will double their future fall risk. And so take this as a teachable moment for the patient and for the family member. Next slide. And so to make an impact, first is assessing your local resources. And my colleagues, Lauren and Brian and Kabir will talk about this, but understand what you have at your as far as your resources. So multiple disciplinary teams. Do you have case management in the emergency department? Do you have physical therapy? Do you have social work? Do you have a geriatrics consult team? And again, probably one of the biggest take-home messages is a fall is really a geriatric syndrome. So assess the patient in terms of the risk factors, educate the patient, and really try to target their fall risk factors. And again, if you could prescribe anything, exercise is probably the best thing you could do for your patient as far as prescribing something. Next slide.
Hi, everybody. I'll just briefly try to contrast quality improvement and implementation science. For many of you, you should be familiar with quality improvement, perhaps less so with implementation science. So quality improvement commonly targets specific local quality problems via rapid cycle iterative improvement. A rigorously done QI project will look similar to an implementation science project, as both can emphasize a theoretically sound basis for the work undertaken. That said, most QI work is usually laser focused on achieving an improvement without much attention paid to how it was implemented. Thus, it is hard to recall what specifically was done, to figure out the secret sauce of how it actually worked, and provide a template for someone else to achieve the same change. In contrast, implementation science generally seeks to develop and rigorously evaluate theoretically sound strategies to address implementation gaps across multiple sites. As such, an IS project is equally focused on the success of the implementation as much as the success of the intervention. To understand the barriers and facilitators, develop a localized change process, and identify which implementation components were successful and which were not. This will help you identify if an implementation actually fails and the intervention itself was not the problem, and it provides shared learning across studies, projects, and contexts. So the contrasting goal for implementation science is to develop generalizable knowledge. Because the differences exist between these two fields, there's opportunities for synergy as well as opportunities for those in both fields to learn from their colleagues.
Thank you, Kabir. So when we think about something like a theoretical framework or implementation versus quality improvement, people get really scared, but it's not that hard. And it's exactly what he was talking about, in that you want to be able to report, what about your site? What about what you did made it work or didn't work? And this is really important, especially if you're looking at a healthcare system that might have a community site and an academic site and a further rural site, or associations with other places where if you change the EMR at one site, you have to change it everywhere. So you really have to think about what program you're going to put in place and how to work in these different environments. And the most common, one of the more common used frameworks is the consolidated framework for implementation research. And it's just going to take you through step by step. It has 5 different domains. I'm going to go through briefly over the first 4, which sort of prepare you for your project. And if you will use this QR code, which is going to be on the next couple slides, it will pull up a worksheet so you can follow along with me and actually start typing in the answers to these questions as it applies to your individual site and what kind of program you'd like to set up. So the first one is you think about the intervention. So the intervention, we want to do some sort of fall risk assessment, and then an intervention. What can I do at my site? What's available? And you want to think about, this guides you through each step. So what's the target group? Who are the exact patients that are going to be in the intervention? Who are you going to include and exclude? The intervention source. So is this something that your hospital director said, I saw something about geriatric EDs in the newspaper. Why don't we have a geriatric ED? Make it happen now. Or is it something that came about organically because your nurses are seeing a lot of people who are really wobbly and it's hard to get them up out of bed and you're really worried you're going to have more falls? You can even look at your fall data in hospital and in the ED, which is tracked somewhere, and say, how does this apply? So you want to look at the strength of the source intervention and the strength of the culture for putting in the intervention. And then there are other things like piloting in a small unit and adaptability, which I'll get to a little bit more later. So that's the intervention. And then you think about the outer setting. And this gets back to why, again, are we doing this? Is it because JHACO mandated it? CMS mandated? Is it because your ED wants to be a IHI, healthy aging hospital system? So what are the external pressures? And you can even include in this pressures from the local area. Did your local counterpart start a geriatric ED and now your hospital needs to respond in kind? Is your community aging? Are you in a really rural community where it's hard to access different resources, and the ED is a place where you can get people and get them connected? So think about what your population needs, local, national, regional. Inner setting is the next one. And again, use the QR code to get this document. And you can think of the inner setting as your health system itself, your hospital, your ED, even down to the floor that you're going to be on. So maybe the inner setting for you is the unit that you're going to do this on, whether it be what's triage like, or what's your OBS unit like, or is it all over the ED? What's the culture there? Have you just rolled out so many different initiatives for COVID that no one can tolerate being told to do one more new thing? then it's not time to implement something new as much as it would help your patients. Sometimes you just have to say, this is not right for us right now. And that's why a lot of QI projects fail, is you don't consider these other things. You don't align it with the institutional needs, and things fall apart. The other thing about intersetting is to go through your IT system. How will the nurses and the docs communicate, or the physical therapists communicate? What's the workflow going to be? Draw all this out. Where are we going to put our walkers and canes? And which staff is going to do that? So going through every single step. And you want to do this with your multidisciplinary team, with people that are going to be on the front lines in your ED enacting the intervention. And then this is my favorite domain, individual characteristics, because this gets into behavior change theory and motivation. You can educate your nurses as much as you want, but if they're not motivated to screen older adults, it's not going to get done. So you have to think about the other things instead of just mandating more computer-based learning things or checkboxes. So, and we could have many more lectures on that, and we will as a group if this is interesting to people. So think about the providers, the characteristics of the patients, and what they need. So we looked at our ED, and initially we'd done sort of a QI system where we just educate people and say, yes, please do this. It's a good thing. And it was not working. So then we surveyed all our nurses and said, really, why isn't it happening? And looked at this in the setting of CFR. And what we found was they thought the intervention was good, and they really thought it helped the health system and it helped the patients, but they had no idea that there were national guidelines to do this. They had no idea that many of them that were even a geriatric accredited ED. And for inner setting, they felt the intervention wasn't very adaptable. So we had to put in exclusion criteria. This is why I didn't screen this patient, because they were intubated. This is why I didn't screen that patient and why I did that one. So it's really helped us increase our screening numbers. Okay, Brian?
Thank you, Lauren. And I want to start to wrap some things up a little bit. When Lauren talks about local resources, and I see Chris just put in the chat, don't forget that local resources may be funding sources. Our entire geriatric falls research program was funded by a local funding source. And then when you're thinking about implementing things, how do you engage your learners? When Sean mentioned time is of the essence, we have found that both students and residents can actively be involved in screening and engaging the patients. But most importantly may be the points that Kabir made about the difference between QI and implementation science. This single slide here highlights some of the common program requirements that the ACGME has for every single residency. And you can see the things underlined about active participation and experience. Two new for this slide deck are the ACGME Milestones 2.0, which start July 1 for residency programs and have a brand new systems-based practice milestone dedicated to quality improvement, where, wait for it, level 4 is all about implementation. So if you work at a site that has learners, or you're a learner, you may be interested in continuing to work with our group and develop your own local geriatrics fall program. And I believe I'm turning things over at this point in time.
Sean? You're muted.
So thank you. So if you're still confused or still yet interested in implementing a fall program, this is actually part 1 of a 2-part falls implementation talk. You can join us at the Academy of Geriatric Emergency Medicine's business meeting this afternoon at 2:35 Central Standard Time. You just go to SAEM and Juno and look for the AGEM business meeting, which officially starts at 1 o'clock Central Standard Time, but the falls part 2 will come at 2:35, and we'll discuss more about QI program outcomes. And I'm handing this over to Kabir at this point.
Yeah, just some tips about how you're going to move this into the future. Success can be helped by aligning interests of your various academic hats. The most obvious alignment is obviously with the research scholarship, as high quality QI is increasingly welcomed as publishable research, usually can go through an expedited or exempt process. Alignment with ongoing hospital interests on quality initiatives is also an easy one to roll in. And then, as Brian mentioned, the ACGME emphasis on QI affords you an opportunity to triple dip with residency education. In terms of finding collaborators, it is likely that you'll be looking across departments. That may be in social work, it may actually be in nursing. If you're at an academic institution or you're affiliated with one, you may find expert collaborators in psychology, human factors engineering, or sociology. And then also consider consulting groups and community groups that may also have expertise in implementation work. And then we would be remiss in not mentioning our co-sponsor for this didactic, the SAEM Evidence-Based Healthcare and Implementation Interest Group. As Brian mentioned, they are ready and willing to assist with your projects. And in terms of funding, this can occur at multiple levels as well. Obviously, in-kind support from your department or at the hospital level can be valuable. This could include release time for you from clinical work to complete the project, but it can also include marshaling members of hospital quality improvement teams to actually help with the work. If you're at a university or affiliated with one, especially those with Clinical and Translational Science Institute awards, there may be internal voucher programs that will allow you to get expertise from implementation scientists, from information technology, and from statisticians. And also look for seed grants, particularly those that emphasize team science or healthcare quality improvement to hire people to help with your work as well. And as Brian mentioned, foundations and community trusts also have an interest in seeing health system improvements. They usually have a regional focus or a topic of interest. Increasingly, they also have an emphasis on care disparities. So certainly you should be looking there as well for funding. PCORI, the Patient-Centered Outcomes Research Institute, has a methodology interest in implementation science. Certainly that would be a funding source to look for as well. And increasingly, the institutes at NIH are embracing the importance of implementation science in terms of their funding opportunities. It is uneven currently, but well worth exploring. That usually means talking to a program officer to figure out if your intervention and approach align with funding opportunities intent. And lastly, the training opportunities. NIH used to offer a training institute for dissemination and implementation research in health called TIDIR, T-I-D-I-R-H, but it did end its live sessions in 2020. There is an open access online modules for it of its last iteration that's called the Training Institute for Dissemination and Implementation Research in Cancer. It has lectures, readings, Q&A across 6 modules. It is worth your time if you want to get the foundations on implementation science. In terms of existing ongoing resources, the Institute for Implementation Science Scholars Program at WashU is being offered as an alternative to TIDIR that is NIH funded. Thank you.
Thank you, everybody, for joining us today. And please sign up, and we're going to have a meeting on June 10th, I believe, and we'll see you again in a couple hours at the AGEM meeting.
Thank you, everyone, for coming. There's a bunch of resources that were put by the speakers in the chat, a bunch of links, so be sure to check it out before you head out. Thank you so much, speakers, for this very interesting topic. Look forward to seeing you all later.
And we'll post these. Sorry, apparently the Google Doc is not working, so I will figure that out. And we'll post it on the AGEM website and the Evidence-Based Medicine website.
Lauren, do you want to post an email because the Google Sheet is not working for one of us, for people to email us?
Yeah, I'm putting my email in the chat.
So once again, please consider joining the group. We have, I think, a really solid plan to work together and move this forward to disseminate. If the Google Doc isn't working, please email Dr. Sutherland, whose email is in the chat.